Hi everybody, thank you so much for joining us for Ataraxis announcement. Today we are talking about Ataraxis NEO, our new test that is built to predict response to neoadjuvant therapy, and we are excited to share with you some of the updates and information about our scientific breakthroughs, about the technology that we've built to accomplish this. I'm here today with JP. JP is our research scientist. JP, thanks so much for joining, and let's talk a little bit more about what NEO even is. Can you tell us a little bit more? What is that test? What are we trying to predict? What is so new about this test compared to what we've done so far, which has been mostly predicting risk of recurrence?
Yeah, so most of the predictive models has been focusing on adjuvant setting, that is, predicting the response to therapy after surgery. However, nowadays, more recently, neoadjuvant setting has been gaining more attention, which is predicting the response to therapy before surgery to shrink the tumor or remove it, such that perhaps less invasive surgery would be used, or we could avoid the surgery altogether.
Completely.
Yeah. So traditionally, there hasn't been a lot of research in predicting the response to neoadjuvant therapy. There have been some models using crude clinical features like hormone receptor status and like crude histology features. And these features correlate a little bit with the patient's response to the neoadjuvant therapy. However, it lacks sufficient precision to guide individual treatment planning.
And when we build a test for recurrence predictions, what we predict is what is the likelihood that the patient will recur within a time frame, or what is the time to recurrence event. So when you talk about predicting response to neoadjuvant therapy, what exactly are we predicting? Because it's no longer looking at recurrence, but it's looking at something else, right? You're looking at only those few couple of months before the surgery, and then looking at what happened at surgery time, right?
So we're looking at the biopsy slice that is taken before the surgery, and we're predicting the probability of this patient reaching pathological complete response, meaning whether the tumor will completely vanish before the time of surgery. And being able to predict this is huge, because if we know which patients will reach the pathological complete response beforehand, then the patients who are likely to reach that status can avoid this, can benefit from neoadjuvant therapy and avoid more invasive surgery. And patients who will likely not benefit from neoadjuvant therapy can just avoid weeks of unnecessary toxicity altogether, and just go for alternative treatment options or clinical trials that the patient might be more likely to benefit.
Sometimes those treatment options, they are really intense and have a lot of side effects. So for example, in triple negative breast cancer, the standard treatment regimen called Keynote, it includes immunotherapy, chemotherapy. Patients get that intense treatment for weeks, for months, and then, you know, with the hope that the tumor will be gone completely, or at least shrinked. But when we talk to oncologists, they typically operate in a way of what is the average response in any subtype. So you'll hear that in triple negative breast cancer, roughly 40, 50, 60% complete response rate. In hormone positive breast cancer, that response rate is lower. It's about 20%, but we still treat many patients with neoadjuvant therapy. And in fact, it looks like more treatment is moving from adjuvant to neoadjuvant setting. And we try to, what you described, you try to shrink the tumor and maybe avoid unnecessary adjuvant therapy or unnecessary extensive surgery. And I think that hope that we can personalize this and not just capture on average levels, but individual level has been there. So now we're predicting who gets complete response, who doesn't, with high accuracy. So we looked at a couple of cohorts that the model has never seen before. We only looked for validation, not for training. And it looks like our performance has been relatively consistent across subgroups, right?
We have tested our Ataraxis NEO model on multiple different cohorts from different hospitals, as well as different subgroups of molecular status, such as TNBC, hormone positive, HER2 negative, and HER2 positive. And our model shows not only good generalization across different hospitals, but also different molecular subtypes.
You know, I think sometimes oncologists also ask, how is it possible that you have one model that is going to work in hormone positive, triple negative, HER2 positive disease? Can you tell more about sort of how even we structure the model? Because we look at both digital pathology data, but we also look at some clinical data, right? We take into consideration hormone receptor status and HER2 positive, HER2 status. So we can probably learn different dynamics and probabilities of complete response, including both pathology features and clinical features. Can you tell more about what are we picking up from what modalities? How do we even integrate this data so that ultimately you have something that's robust in all subtypes?
So yeah, what the model takes as input is, first of all, pathological features extracted by our AI foundation model. And this model is trained on a large collection of unlabeled pathology slides to extract rich and generalizable morphological features that can be used for any downstream tasks, such as predicting response to neoadjuvant therapy. And in addition, we also utilize clinical variables, like you mentioned, hormone receptor status, and some patient age, and some basic histological features, such as IDC or ILC. And the model is able to, we train this model to not only to predict the target task of interest from each of the information separately, but also from a fused representation where the model combines information from both modalities. And what it does is we are making sure that we are extracting useful information from both of the information rather than ignoring one of them. And also we finally combine the information together such that the downstream performance will be better than just utilizing either of the modalities alone. And yes, by doing so, even the part of even the model prediction that utilizes the histopathology slide embeddings will also be able to tell apart. We'll also be able to utilize the information about the patient's clinical variables and be able to learn different dynamics between different molecular subtypes and be able to create accurate predictions for this different group of patients.
Yeah, I think something that we have seen in this research and in other research is that there's a lot of signal that comes from digital pathology imaging on its own. Of course, when you combine it with some clinical data, then it actually superpowers it, and the combination of digital pathology with clinical features is this perfect combination, and you get better models that are more predictive of treatment response than if you looked at any of those modalities alone. And we've seen it before with recurrence prediction. Now we're seeing this with neoadjuvant therapy prediction. I also, maybe going back to utility, I think one thing that is worth to highlight, and how do you apply this, is that now you can identify patients that are almost counterintuitive to oncologists and to surgeons, because again, typically you just look at averages and maybe 20% of patients have complete response. But now we can see that if we divide those patients into groups based on our score, and we presented this for the first time at San Antonio conference, there are patients that with the lowest probability of pathCR, and we can identify even in subtypes like triple negative breast cancer, HER2 positive breast cancer, that have much lower PCR probability and PCR rate than on average in that subtype. And on the other hand, patients who have 60, 70, 80% probability of achieving pathCR in the subgroup of patients with highest score of highest likelihood of achieving pathCR. And I think it can have pretty profound consequences on how surgeons and oncologists make those decisions, especially that they often end up in multidisciplinary boards. And it's a question of, okay, who actually needs to go through neoadjuvant therapy versus go to surgery first? You started talking about sort of what drove us to developing those models and how do you combine information from multiple modalities, which that is one of the things that we had to solve. How do you, in an effective way, learn from digital pathology? And that on its own is a big technical challenge that we had to overcome. Then how do you integrate clinical data with it? Would you say that this is like the biggest part that led to the development of the NEO model? Were there any technological and scientific breakthroughs that we've had over the last couple of months that allow us to predict pathCR with such good performance?
There were a couple of different things that led to the success of the Ataraxis NEO model. First of all, we have a really good AI foundation model that extracted all these useful features for different downstream tasks, which is the foundation of our success. Another thing is, one of the things we found is that our bigger product, Ataraxis Breast, which learned to predict the risk of recurrence, is actually learning something useful for the something useful that can generalize to the task of predicting pathCR as well. So it's learning that what kind of features are correlate with more aggressive form of cancer, and this information is also useful for the predicting the response to the neoadjuvant therapy, which with the transfer learning we can learn to utilize for this task as well.
Yeah, that's so an interesting point is that we did see initially that just the recurrence score was associated with pathCR. It wasn't completely random, which I think it's also expected that you can infer probability of complete response based on aggressiveness of the disease and what is the likelihood of recurrence. It kind of ties into this world, but they are not 100%. There's no overlap all the time. So the model that is built for predicting path complete response, it finds other patients who are likely to respond to neoadjuvant therapy than model that can predict who has high risk of recurrence. So it made sense to us to have those models separately, right? It wouldn't make a lot of sense just to apply the recurrence score for predicting neoadjuvant complete response. Would you agree with that?
Right. Even though those two tests are somewhat related, it doesn't make sense to just train one model for predicting risk of recurrence and just use it for pathological complete response. Just because the model performance will be better if it's trained on the actual task of interest. And also for the downstream task of predicting pathCR, there are also a lot more information that we can utilize instead of just training the model with the information of whether the patient reaches the complete response or not. We can provide more granular information, such as from what kind of starting TNN staging, what kind of resulting TNN staging the patient reaches, and also we can train the model to predict this separately for tumor and lymph nodes. And this kind of additional information not only helps the model to learn from more richer signal, but also it makes the model prediction more useful for the downstream task, because being able to learn whether different parts of the tumor will respond differently can also help guide the individual treatment planning.
Yeah, I think that was one of the most surprising thing, that you can predict response in just lymph nodes, for example, and instead of you can absolutely predict complete response, and we've been primarily focused on predicting what is the likelihood of pathologic complete response. But then even looking separately at the nodal status, you can predict response in nodal status separate from response in the primary tumor, which has, I think, for surgeons, especially big implications, and for patients who are considered for axillary surgery, because the extent of the surgery, it depends a lot on whether you have disease in lymph nodes or not. So if you know that the disease is going to be gone in lymph nodes, then it can completely change the decision making around neoadjuvant therapy. And if you would need extensive axillary surgery upfront versus going through neoadjuvant therapy but then having negative lymph nodes, then it can change quite a lot in terms of making those decisions, who needs neoadjuvant therapy and who doesn't. And we've looked at cohorts from multiple sites, and the performance has been quite robust, right? Even though the data came, it wasn't one institution. We looked at patients from multiple sites around the world.
Yeah, to our knowledge, we built one of the biggest data sets for building predictive models for neoadjuvant therapy response. We acquire something like about 1,000 patients from multiple different institutions for training, and we are evaluating as well on a diverse cohorts of test sets from different hospitals involving multiple different cancer molecular subtypes.
Yeah. So JP, maybe let's talk about the future and sort of what directions are we pursuing now. I think what I am the most excited about, and feel free to comment on this or something else, but I think being able to predict complete response as we do right now, sort of agnostic of any given treatment, is the first step. And just knowing broadly, if this patient received standard of care, this is the assumption that we're making currently, that this patient, where we predict likelihood of complete response, is going to receive standard of care, whatever that standard of care means. But moving forward, we will probably try to answer questions of what the complete response looks like in different treatment scenarios, right?
Right. So for our first model, we have been kind of restricted by the amount of data set size we had. And then if we split the models learning in between different subgroups based on what kind of treatment they received, then we'll have somewhat very small data set size to learn anything from that. However, as we acquire more and more data, yes, we hope to not only just predict the response, assuming the standard of care, we will want next versions of the model to predict different probability scores for different types of therapy, so that it'll provide much more informative guidance to the clinicians and patients.
Yeah. I think this is going to be one of the most exciting directions, and we are going to also try to validate our model using data from clinical trials. So right now we've looked at multiple cohorts from different institutions that had very diverse patient groups with different molecular subtypes, different treatments. But now to ultimately prove this utility, we're also looking at clinical trial data and want to show, can it actually be validated even further, even more independently than we've done so far. JP, anything else to add on the technical side that led to the discovery of the NEO model and making sure that it works properly?
So far, some of the predictive models on neoadjuvant therapy has been using some information from histopathology slides, and those are mainly extracted by the pathologist, human pathologist. So we have been using the information from pathology slides so far. However, I think where AI really adds benefit is being able to extract information from the pathology slides in a way that doesn't depend so much on individual pathologists, and also potentially be able to extract features that are not necessarily detectable by human pathologists or not thought of as most important right now. Being able to utilize all of this information using the power of AI and power of AI foundation model, I think is really important for the success of our model.
That's right. I do think it's worth bringing up that the entire way that we've designed those models is that we can capture some new features that are still morphology based. They're still grounded in biology. They might be more difficult to explain than a predefined feature, but it's very difficult to identify, pre-specify one feature in such high dimensional and complex data like digital pathology. So we know that there's precedent for identifying morphological features that are associated with neoadjuvant therapy response, and TILs, tumor infiltrating lymphocytes, are the best example. In triple negative breast cancer, patients receiving immunotherapy, TILs have been found to be associated with complete response and response to immunotherapy. So we know that there are features in morphology that are associated with response, but we have been building those foundation models. And maybe as a reminder to everybody, because we've been working on foundation models for a while, and we've built already a couple in-house. Some we've released, so some we haven't yet. But on a high level, what is the foundation model, and how are we using this in the development of NEO?
Yeah, so foundation model is something that's really state-of-the-art of deep learning research, where we can really enable the model to learn by just looking at the image itself without any access to the ground truth labels, without any assumption or knowledge of what we want the model to do in the downstream down the line.
So it's just looking at a lot of images, and then it's trying to understand what the images are made of, and it builds sort of the features that are based on the image, but you don't know exactly what they are, or do you know what they are?
When we train Vision Foundation model, we don't have to make any assumptions or any guidance in what kind of features it needs to learn or anything. It just, there's still a lot we don't know about how the training Vision Foundation model exactly works. But basically, it's learning to identify and record all the features that makes each feature unique, something that represents each of the image the most, such that it can be useful for any kind of downstream tasks.
Yeah. So one of the downstream tasks is the neoadjuvant therapy response prediction, but the same foundation model that we've built is applied to NEO model to predict neoadjuvant therapy response. It can be used for recurrence prediction, for therapy response prediction. So it's all coming from the same underlying model, right? And a set of morphology-based features.
That's really what's amazing about this vision foundation model. Once you utilize a large unlabeled data set to build a strong foundation model, it can really be used for many different tasks without having to retrain a new model for each of the tasks. And so once we have strong baseline, once we have one strong vision foundation model, another avenue of research is also being able to slightly fine-tune this model for different tasks. And once we have capability of doing that, we can also use something called mixture of experts. Based on one foundation model, we can learn slightly different fine-tuned version for different tasks, and then we can, and the model can utilize this different slightly fine-tuned version of the knowledge together for any novel tasks that we may want to predict but not necessarily have a lot of data for. That's another exciting revenue of research.
Well, JP, thanks so much for telling us about it, and thanks for everybody for joining in, and we hope to keep you posted over the next couple of months about our future research and product releases.